Hi, it's Dr. Jeff Myers, and thank you for joining me for this repeat presentation of the Division of Palliative Care Grand Rounds delivered on December 4th. The topic for the rounds in general was social accountability, and in particular harnessing the power of relationships. I specifically addressed the important relationships for the division, which is that with the Department of Family and Community Medicine. As I go through the slides, I'd ask you to reflect on your story and what it is that makes palliative care make sense to you, what it is that keeps you committed to the field after however long you've been practicing. And I also would request that you keep in mind the stories of your primary care colleagues and the relationships that develop over so many years with their patients and families. These are the two things that would be helpful to be reflecting on as I go through. I'm going to begin here with what I'm envisioning as the long-term outcome of a focus on relationship building with our family medicine colleagues. And it's represented by two phone calls I recently received while I was on call from colleagues who practice in the academic family practice teaching unit in our local setting. I'll give you a moment to read these two statements as they really represent what I envision as a successful future state. I want to start by reinforcing the increased relevance and awareness of the need for palliative care. Choosing Wisely Canada is a massive national campaign with the aim of facilitating patients and having conversations about, in general, unnecessary tests and procedures, but mostly it's intended to help physicians and patients make smart and effective choices that are based in evidence. So national specialty societies were asked to develop lists of things that patients and physicians should question, and displayed here are the top 5 that were recently released by Oncology. 2 of the most important things that Oncology selected to communicate address palliative care, with one being active chemotherapy instead of focus on symptom relief in palliative care, and patients with advanced cancer are unlikely to benefit from chemo. And the second one that was included in their top 5 was not to delay or avoid palliative care for a patient with metastatic cancer because they're pursuing disease-directed treatment. So we might have expected this from Oncology, but the expanding reach of evidence for the role of palliative care is really made evident in Choosing Wisely campaign from the States, where that originates. And last week, a series of recommendations were released, in particular for the American College of Emergency Physicians. And the third most important care element identified by the emergency group was not to delay engaging available palliative and hospice care services in the emergency department for patients likely to benefit. This has massive implications for the field of palliative care because it represents an expanding role for palliative care and a potential impact on clinical volumes. With that in mind, turning to our current landscape and reality, what I'm showing here is the number of new consultations our team has received over the last several years. And you can see that between 2014, we're projecting, and 2011, a doubling, essentially, of the number of inpatient new referrals. When you factor in the fact that our aging population continues to make an impact over time, and we really are only at the very beginning of increased volumes that we can expect over the next 20 years. The bottom line is that palliative care clinicians simply cannot provide all the palliative care that needs to be delivered. So thinking about the population served by the Division of Palliative Care and reflecting on the number of patients who would benefit from an earlier integration of the palliative approach to care, there is ongoing inequity in the timely access to palliative care approach to care in the GTA. By this I mean effective symptom management, care planning, information sharing, and person-centered decision-making much earlier in the course of advanced and curable illness. Although some fantastic projects are occurring throughout the GTA, it's important to discuss a reality, which is the GTA is half of the province population, and to effectively integrate a palliative care approach much earlier in the course of illness is a massive undertaking. The real-life impact of our aging population was addressed during the recent Department of Family Medicine retreat, strategic planning retreat, where our colleagues sent a very strong message of help. They communicated to me since then and during the retreat a real desire to provide the care, palliative care to patients, and a request to just give them a hand with this. The big question that keeps coming up time again is, how do I have the conversation? about advanced care planning, about progressive illness. And most importantly, our colleagues are asking us to help them to teach this well. So the need for us to be thinking about the Department of Family Medicine is really underscored by the Auditor General of Ontario's report, which will be tabled next week to Cabinet. And it's expected that family health teams in particular will be signaled out as a group to focus on in terms of the primary palliative care delivery. Absolutely, the logistical and historical and real challenging barriers that exist in our region are important, but I would ask that you parking lot these for a moment. It's no doubt different approaches and different models are necessary for different regions, but here's the thing. Our colleagues are asking for help. They want to teach better, they want to provide care better, and if you consider the impact of would you be surprised question that's being adopted in so many different contexts, who will care for all of the no's in response to the surprise question? So the theme for the rounds in general is social accountability, and how does this all fit together? Because we can't do it all, I'm taking you back to the first part of the presentation for the reasons that kept you and brought you to palliative care in the first place, and I'm asking how those reasons apply to this question. Does the Division of Palliative Care have a role or even a social accountability to support and teach a workforce that better integrates a palliative approach to care? I hadn't thought of myself as being accountable for the teaching I do. I just enjoyed it. But if we are to have the time to provide the care we can provide and we want to provide well, then we must consider our primary care colleagues' stories and the relationships that they have in order so that they can provide a great deal of the palliative care that needs to be delivered. So how do we think of ourselves as being socially accountable? You know, I really think it is an element of all of our stories. It's in every learner interaction, it's in every phone call that we get from a colleague for advice. Being socially accountable is actually providing palliative care. It is what we do. It's our fabric and it's what unifies all of us. And so in follow-up to the strategic planning retreat, I presented to the DFCM executive on the topic of an added layer of support in the Division of Palliative Care. My intent for the presentation was to galvanize the leadership within Department of Family Medicine and really capitalize on the strategic planning retreat, which had as its slogan 1,400 faculty members, many of whom practice in academic and teaching units as well as community practices, providing care to 1 million people. And I challenged the DFCM leadership using the example of advanced care planning. And I proposed to them, you know, set as a goal for yourself, have 1 million people with their values and wishes documented, and then their family member decision makers involved in these conversations, so they're worrying much less and making much better decisions. And healthcare team members have access to and can revise documentation of these conversations over time, anytime. And I left them with a slogan or a public health campaign strategy of the department caring for 1 million people for the rest of their lives. This theme or this slogan very subtly conveys a certain message. And I left them with a proposed vision for the relationship, which is the Department of Family Medicine leading the transformational change to improving care for the people in the last year of life and their family members. And my message to them really that underlies this is, you can do this, you can provide this care, and how can we help? And so what I've done with this presentation and with the work over the last couple of months is really set the stage for folks at their local sites to start thinking about how they can concretely integrate with our family medicine colleagues. Why use the Department of Family Medicine in terms of moving forward with building capacity? Because it's a place to start. And as I really reflect on it, in all honesty and fairness, it's a place to continue. We must build on our regional success, and I could not let the success of the Toronto Central Palliative Care, Integrated Palliative Care Program not go unacknowledged, as the Minister's Medal for this year went to the CCAC in Toronto Central in partnership with the Timmy Latner Group. It's from this success that the division can further build relationships with our academic family practice teaching unit colleagues. So how can we do this? What steps can we take? And it really is about thinking of ourselves as integrating in very formal ways at our local sites between our Division of Palliative Care faculty and members, and the Department of Family Medicine faculty members and learners. And some of the strategies that you can think about related to clinical skills or teaching skills is that the department members will develop and maintain these, and that can be facilitated by division members. In terms of the direct care provision, of course, we're talking about family medicine providing this care, but thinking of ourselves as mentors and providing support. Examples of some of the tools that are likely to surface over the next period of time are advanced care planning conversation templates and LEAP, the Learning Essentials Palliative Care Interprofessional Professional Development course, which is going to be the standard for Ontario. So I'm taken back to my ask at the beginning of the presentation and around reflecting on your stories and what it is that brought you and keeps you in this field. And I would say to you that the stage is now set to build our own relationships and advance at the local level in very formal, concrete ways what these relationships look like in an effort to really share the load of the palliative care delivery over time. Many thanks.